Hello, everyone. Welcome to the Physician Employment Model webinar. Thanks for joining us late on a Monday evening. I guess not so late for those on the West Coast. We hope that this will be a productive hour to an hour and a half. Our target audience for this is a combination of fellows, residents, and early career physicians, and even maybe some mid-career physicians who are thinking about a change in their career at this point. So we have an excellent panel of diverse participants from various different types of employment models. And so the Community Practice Committee was lucky enough to have them all participate in this. And we would like to make this as lively and as interactive as possible. And so we really would like the audience to participate, and we'll be able to share your questions with the group so that we can all learn as much as possible from our panelists. So without any further ado, we will have our blue sky operator give us some introductory instructions on our platform. Thank you.
Great, thank you so much. Before we get started, I'd like to take a moment to acquaint everybody with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click the text box and type your text. When finished, simply click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete this survey as it will help the SVS Community Practice Committee plan future web events. At this time, I'd like to hand the microphone over to our moderator.
Great, thank you, Kai. I just wanted to introduce our faculty participants today, all of whom are taking time out of their busy schedules to be here. We have Dr. Dan Clare, Dr. Ulka Sachdev, Dr. Russell Sampson, Dr. Brian Santine, and Dr. Samantha Stradley. I'd like to actually have each one of you just give us a brief one-liner on where you practice and what type of employment model you currently exist in. And let's start with Dr. Sampson.
So I'm part, or have just left, a 6-person private community practice group in Sarasota, Florida. We've been like this for many years. We function out of essentially 2 hospitals, dominantly out of one Sarasota Memorial Hospital.
Wonderful. And Dr. Sachdev?
Thank you for inviting me. I'm in an academic practice at the University of Pittsburgh Medical Center. I'm part of a group of, I believe we're at 18 surgeons now, covering a wide range of hospitals in the area. And I also have a basic science laboratory where I'm able to do some translational work studying peripheral arterial disease.
Thank you. And do we have Dr. Clare on the line yet? If not, we will move along to Dr. Santine.
Sure, thank you, and thanks for the opportunity. I am in solo private practice in Wilmington, Ohio. It's a small rural community about halfway between Columbus and Cincinnati. And I started that practice on my own back in 2013 when I finished up my vascular surgery fellowship. And the hospital there is, again, a 165-bed facility that I cover.
Wonderful. So the polar opposite of what Dr. Sachdev just described a minute ago. And then we have Dr. Stradley, who I believe is on our screen somewhere here.
Yes, I'm here. So thank you all for joining us tonight. This is a very important topic. And so thank you for taking time out of your busy schedules. I currently work for the Permanente Medical Group, which is part of Kaiser Permanente. For those of you that don't know much about Kaiser Permanente, we are the largest managed care organization in the United States. We currently have about 12.5 million members. And within Northern California, we have 42 vascular surgeons. In my immediate area, which is the greater Sacramento area, we have 8 vascular surgeons. So thank you all for joining.
Thank you. And Jamie, if you can move on to the next slide, that would be great. Just to kind of reiterate what our panelists just described was kind of a diverse array of employment models that exist within the world of vascular surgery. And the impetus behind this webinar was really born out of some SVS Connect threads and activity that recurred many times over during the past year about different types of practices and how during training, sometimes, you know, there's very little exposure to the full breadth of these practices. And so this was seen as an opportunity to be able to expose folks to that diverse reach of opportunities. And so the various models, and these aren't all the models, but these are just some of them that we're representing today, are private practice, solo, such as Dr. Santine described, versus private practice in a more of a group setting, as Dr. Sampson mentioned. And these groups sometimes utilize residents or fellows, or primarily physician extenders. The other major categories we are trying to cover tonight are employment within an academic health system with or without research and clinical duties. And Dr. Sachdev can speak to this in volumes. And then integrated health systems is exactly what Dr. Stradley was referring to with the Kaiser system, and we'll utilize her expertise on that. And so without any further ado, I just wanted to let the audience know that we're going to break down our series of questions for our faculty into 3 broad categories. The first category being clinical questions, the second being administrative duties and aspects of their individual practices. The third category is kind of a catch-all general set of questions about unique aspects of their practice, including things like mentorship and aspects of daily practice that pertain to physician wellness and burnout, which are very hot topics right now amidst a variety of surgical practices. So if we can move on to the first category. So since Dr. Stradley, since I see you on the screen, we're going to go ahead and start with you. And our first question in this category is whether or not you could please comment on your satisfaction with the volume and complexity or case mix within your practice, and how directly you are actually involved in patient referral patterns, which may impact your case mix.
Okay, great. Glad to start. So within Kaiser Permanente, when someone becomes a member, we function as essentially a self-sustained ecosystem for all of their healthcare. And essentially that means that we coordinate the care for the entire patient experience. So we don't really get referrals per se, but we are responsible for managing the care of all of our members. So within the greater Sacramento area, which includes both Roseville and our 2 Sacramento facilities, we have approximately 2 million Kaiser Permanente members. Within that, we cover all the bread and butter vascular surgery cases. We do revascularizations for chronic limb-threatening ischemia, cerebrovascular disease, repairing of aneurysms, dialysis access, varicose veins, just about everything that you would cover as a vascular surgeon. We do have people within our group that have things that they sort of carved out as their niche. So for me, I trained with Julie Freischlag, so I cover thoracic outlet syndrome. And then my other area of interest is pelvic congestion syndrome. So I have my partners not only within the greater Sacramento area, but within our Northern California Kaiser system that refer patients to me specifically for that. So I'd say the only real competition per se that we might have is with our interventional radiology group, but we work very well with them. We're not really competing for cases. It's more of a collaboration because there's not an incentive to take those cases away from our interventional radiology partners.
Excellent. Thank you so much. Dr. Sachdev, this same question to you. In your large multi-hospital 18-partner university system and with your balance with research, how is your case mix kind of determined, and how are you involved in your referral patterns?
Yeah, that's such a great question. So our hospital, the way that our hospitals work is they are geographically in fairly distinct places. I'd say that there's one group of hospitals that are within a 5-mile radius or so of each other within the city itself, but some of the other hospitals are in more suburban and almost more rural areas, or not rural, but more suburban kind of areas outside of the city. So I have found that one still has to kind of build that referral practice, even though we're part of this big group. If you want to do certain types of cases, you want to maintain a good case mix, you do kind of have to get out there, put your name out there, give talks, make people aware of the services you're providing in your particular hospital. And I've kind of had the opportunity to do that where I am now at Magee Women's Hospital, where my former partner, Ellen Dillevu, had gotten such a great start in this. And when she left, I ended up taking over that role in this particular hospital and have really been working to expand the types of cases that we can do there, which has been a really kind of interesting challenge. And it really, I think that there's a lot of times this myth that the patients just come to you, and that's not the case. You do have to kind of work at it and show that you can do a good job and take good care of patients and call referring doctors and be available. You have to do all of those things. And I feel like in the kind of a practice where I am, I have actually had the opportunity to work in a few different hospitals within our system, including in the VA, which is a very different kind of experience. So in answer to the question of how directly involved am I in patient referral, I feel like I am pretty involved. And I actually enjoy that part of the practice.
Wonderful. I think you've already busted some myths regarding, university settings where there certainly may be the impression, especially as a trainee, that these patients kind of magically show up on your OR schedule from somewhere. So the hustle is real, no matter what environment you're in. So thank you for that perspective. Dr. Sampson, can you please comment and add to the mix here on volume, complexity, and how you in your large group practice or very busy group practice, you've been able to be involved with patient referral patterns?
Well, thank you again. I agree with Ilka. In community practice, you really have to go out there and hustle for your work. At the same time, however, in Sarasota, our group is essentially 6 people. There are 3 other vascular surgeons in Florida, 1 working in a multi-specialty group and 2 basically on their own. And so our group is kind of recognized as the go-to vascular group. So we do get patients just because we are Sarasota vascular specialists. But individually within the group, we work individually. So we basically are a group of 6 people as individuals. And so you have to hustle on your own for some of the work that you want. So you can develop a practice in a specific area if you have any specific interest. At the same time, we also have our own angio suite, and we also have our own vascular lab. And that is a source of direct referral. So people do recognize that if they want to have a patient tested for vascular lab testing, it's often much more convenient for the patient to come to our office and to go to the hospital. And that is a source of patients for us. And so too with the angio suite. As far as the complexity of the work that we do, in our practice, we do everything. We very rarely refer out. Only time we refer out is we have an infected graft and we send it to Tampa because we can't be bothered with it here in Sarasota. And you know, Tampa General has had a long and a storied career of taking care of infected grafts, so we're thankful to have them just an hour away. But that's essentially what we do, is we hustle for the work.
And it sounds like years of building those referral patterns is what keeps these practices going as they are. So the new partners benefit greatly from that, I'm sure. I think we have the opposite end of the spectrum with Dr. Santine, who's a little bit more in a rural area. I'm curious to hear your comments on this question.
Sure, thank you. You know, I am what I would consider a bread and butter vascular surgeon. You know, due to my geographic location being the only vascular surgeon within about 55 to 60 miles, the primary care practices located within kind of my catchment area have routinely supported my practice from day one, again, when I opened them in 2013. That being said, there are 3 large metropolitan areas, Columbus, Dayton, and Cincinnati, all within reach of my practice community. And thus I run my practice as a small business. And as a result, I market my practice and the vascular lab that I have in my office at least once a year. Typically right around Thanksgiving, I drive out to meet with each of the referring physicians and APPs. I give them a nominal gift of some delectable treats for their office staff and a postcard or a holiday card, if you will, with a nice photo of myself, my office staff, our therapy dog, and remind them that at Thanksgiving, my practice is thankful for their support. You see, I do this at Thanksgiving because at the holidays in December, everyone's giving each other, you know, a bottle of wine or chocolates, and they get lost in the crowd. No one does this at Thanksgiving, except my practice. Hence, I stand out from the crowd. Right, with regards to volume of cases, I typically perform 15 to 20 procedures per week, divided up between the OR, the interventional suite within the hospital that I'm connected to, and in a procedure room in my office. So I'm busy, but not too busy. In essence, I think I have pretty much an ideal work-life balance, in my opinion.
That's wonderful. Thank you for that insight. It's very much a different perspective than kind of what we just heard. And great tip on the Thanksgiving strategy. I like it. So we're going to go through to our second question. If Jamie, if you can forward those slides. So, and some of you kind of did mention this already in your first set of answers. So if you feel like you've already answered some of it, we can move along. But we'll go backwards this time, since Dr. Santine, since you're on the screen, we'll start with you. Do you have the option of creating a niche practice within your employment model? And are there limitations on certain types of cases your practice performs because of, in your case, your kind of geography and the fact that you don't have a lot of additional help necessarily?
Yeah, no, exactly. You know, being a one-man band, you know, if you will, in solo private practice in rural community, you know, I had to recognize early on that while I was trained to handle any vascular catastrophe to the human body, maybe it wasn't such a good idea for me to be handling every major vascular catastrophe at a 165-bed, you know, rural facility, which there is no critical care intensivist or pulmonologist. You know, if somebody's my patient's on a ventilator, it's either the hospitalist or myself running that ventilator. So, you know, I limit my practice, you know, to bread and butter vascular cases, you know, elective carotids, TCARs, elective EVARs, dialysis access, PAD, and, you know, with venous disease, quite honestly, being the biggest portion of what I do. You know, ruptured aneurysms, we don't do them, you know, because we don't see them enough to have an OR staff that's competent on call 24/7, you know, for a case that you might get once per year. You know, there is a real reason why we have large tertiary care centers in this world. And I can have a helicopter at any one of 3 major ones within 15, 20 minutes. So, it really allows me that opportunity to tailor my practice to be tolerable to what I want to do so that I don't get burnt out, right? Because I know that's been a big topic of late. People feeling burnt out, getting calls at 3 o'clock in the morning. I'm a one-man band, and I can't honestly, knock on wood, tell you the last time I got a 3 a.m. call. So, yep.
Don't jinx yourself. But I think that's great advice in terms of knowing one's limits with the intent of best outcomes for patients, given existing resources. I think Dr. Sampson, if you don't mind commenting on this niche practice concept.
Yeah, we don't have any trouble setting up a niche practice. In fact, recently one of the newer doctors that joined us, Jason Wagner, has established himself as being more of the go-to dialysis person. But you can do anything in the private practice. I don't think that there's anything in a large community practice, in a big community hospital like ours. We have 800 beds. We have 2 hybrid rooms. As I said, we have our own angel suite. I think we can do anything within our area.
Wonderful. Dr. Sachdev.
Thanks. Yeah, so we definitely have the opportunity to create a niche practice, but I will say that in a practice of 18 surgeons, I mean, there's obviously even going to be some competition amongst your partners. So yeah, if you want to create a niche practice in complex aortic aneurysms, you will run into a lot of competition that way. I mean, that's just the way that is. So, I feel like I have been able to carve out a niche for myself partly because I do basic science research as an aspect of what my job is and what my role is. And I try to tailor what I do clinically towards the projects that I'm doing, not all the time, but some of the time. But, I was trained to do abdominal aortic aneurysms. I love doing them. And there are times that if I get the opportunity to do it, I'm going to do it. And I feel like we have enough support in our hospital, and we have enough support close by to help if I needed to. If it's something very straightforward, I will take care of it. I don't want to say it's a smaller, I guess it is a physically smaller hospital than the main tertiary place that's up the hill, like two and a half blocks away. But we still are able to get quite a lot accomplished there. And there are some aspects of a niche practice that I get a little resistant to, because I don't want to kind of get pigeonholed, which I know is not a great word, but in just doing one thing. That's, I think, part of the reason people really love vascular, is because you have the opportunity to do so many different things. So I try to keep it as diverse within reason. I will try to keep cases at McGee when I can. And if it's something that's really too complex, I will take it to the other hospitals that may be more equipped. And the benefit of being in the type of practice that I'm in is I have the ability to do that.
Excellent. Thank you. It sounds like people even within your group probably vary that, and some might be more broad-based, and others might enjoy just sticking with maybe dialysis access, as Dr. Sampson said, but then occasionally doing some of the other cases. So wonderful. And then I think Dr. Stradley, if you don't mind commenting on this question, which I think a lot of people may not really within the Kaiser Geisinger type models. I'm actually curious about your perspective on the concept of a niche practice in that setting.
Yeah, certainly. So again, we have about 42 vascular surgeons within Northern California in the Kaiser Permanente system. And certainly there are those of us that have sort of carved out certain things that we like to do. And one of the nice things about being in such a big network of hospitals is that you can usually find a partner within your network that wants to take on these cases, and you yourself can actually follow the patient to that location and do the case with them. So for example, median arcuate ligament syndrome, I maybe saw one of these during training. And of course, my first month of practice had a patient that had been worked up for everything else. And this is what they, seem to have. So I was able to bring the patient to another location within Kaiser and do the case with one of my partners there. And, essentially learn from them how to do these cases. And he's very happy to take on these cases within our system. So it's nice. We rarely refer out of the Kaiser system, even the emergencies, because we have plenty of partners to come in. If I have a ruptured abdominal aortic aneurysm, I usually call in one of my partners to do the case with me. And so we have a very supportive system and the ability to handle a lot of different complex pathologies.
Excellent. Thank you for that perspective. And I do think that Dr. Claire has joined us as well. Dr. Claire, if you're on, if you don't mind just briefly introducing your practice model, that would be great.
Yeah, so the practice I'm in now is a 5-person vascular surgery practice. It's we're employed by a health system, but we have a link with an academic center, medical school at the University of South Carolina. And the path to that has been a little bit different because I was the first vascular surgeon in the entire community. And there are now 5 of us and probably a need for more in a catchment area of like 1 million people. And to answer this specific question, we have chosen, and I think this is something along the model that we had in Cleveland as well, to try and have particularly complex areas dealt with by 1 or 2 individuals. And I think as we move forward in vascular surgery, to have everybody in a 5, 10, 20 person practice doing first rib resections, doing complex endografts, doing open complex aortas, I think is going to be problematic because we're not going to have enough people who have the experience to become proficient at all of those things. So within our practice, what we do is we have people who are dedicated to particular areas. We have someone who does first ribs. You see a patient with a first rib, that individual is the person who helps with that surgery, or at least helps or will even take over the care for that patient. And the same is true for open aortic surgery. We always want to have 2 surgeons on a complex aortic surgery, and that still allows us to have trainees in the operating room to work with us as well. But it assures that we have 1 person who gets a lot of experience in areas where we really feel that the risk is high and the outcomes are critical to be valued in the community.
That's a great answer, and I think is consistent with kind of what Dr. Santine had mentioned about kind of knowing our limitations and ensuring good outcomes for patients by ensuring qualified people are taking care of them. So with that, we'll move to the next question, and we'll make this a little more rapid fire since we have a couple more sections to get through. And we'll start with Dr. Claire, since you're already on the screen. How do you navigate your relationship with industry or introduction of new devices into your practice?
We have what's called an SVAT, or a surgical value analysis team. And if you want to bring a new technology in, you present it to a group of surgeons within the facility who assess the technology to determine whether it's viable or provides value. And that includes an assessment of cost as well as an assessment of outcomes as well. And what I would also say is, I think for my own practice and for things that I enjoy doing, I like actually looking at new technologies, assessing them in trials. And so I think that's been a critical component of us incorporating new technologies within our practices. So, we are now in 6 different trials with devices that are still in trial. And honestly, I thankfully am in an environment that where the university values that and the health system values that as well. And I think that for me was a critical aspect of wanting to be where I am doing what I'm doing.
Thank you for that. Dr. Santine, can you comment on this? You'd mentioned that you are doing TCAR in your hospital, and I was curious as to kind of how you went through the process of introducing that new technology into your solo practice.
Yeah, great question. I really typically allow others to really vet new technology prior to bringing it on board. And I'm also cognizant of the cost to new technologies for my institution. I feel a real fiduciary responsibility to the vascular service line in my hospital. So, for example, I built up my outpatient venous disease patient population for a few years before proposing to purchase an IVUS setup. I was methodical about the approach. I presented the ROI, the case logs of my practice to the hospital CFO. And as a result, it was a pretty quick turnaround for an IVUS to show up in my lab. That being said, on smaller items, we can be quite nimble. For example, when venous specific stents became approved, we had them within no time in my facility so I could begin using them. So I think you just have to be methodical about, the approach. But fortunately, I don't have layers upon layers of red tape to go through either. It's sitting down with the guy making, writing the check. And it's pretty nice being in a smaller institution.
That's fascinating. Very, very different than some of the larger university systems. Dr. Sachdev, can you comment on that since you're in behemoth of a system?
That's true. But, the nice thing about where I'm located currently, it is a smaller hospital. So, and I had a very similar experience to what Dr. Santine had just mentioned, is that we kind of had built up a venous practice where we were. And so then when we went in with the ask for the IVUS, we got a very similar response, came up with the ROI, and it actually was a good learning experience for us. And because even though this hospital is part of the bigger UPMC program, dealing on a smaller level was actually really a great education for me. And it was much easier, I think, to get what we needed, because it was not difficult to kind of show how this would be useful. And when it comes to newer technologies regarding newer stents and things like that, there are a number of people in my group who are very involved with industry and kind of involved in industry trials. And I get to kind of ride that wave. So they kind of introduce the new technologies, and then it kind of dissipates to the other hospitals. We get to be involved in trials. I try to get McGee on some of the local trials for newer stent grafts, et cetera. And that's how we get our, that's my role. So I'm not like one-on-one with the reps necessarily bringing the new technology, but I take advantage of it once it's approved.
Excellent. So it sounds like a hybrid approach. Jamie, if you don't mind forwarding to actually 2 slides so we can move through into the next section. So the next section, and I'm going to turn it over to Dr. Brahmanandam. It's related to administrative aspects of practice. And so I'm going to turn it over to her, and she'll go through these questions and get your perspectives on it. Thank you.
Good evening, everyone. Thank you so much for joining us tonight. So I'm actually going to do a slightly different version here. We have 5 questions, which I think all the panelists have reviewed, but I'm going to have each panelist discuss each question. I'm going to assign a panelist to each question. And then at the end, if anybody would like to add to any of those questions, they're welcome to. So for our first question, I would like to know, this is for Dr. Claire, how much involvement, I'm sorry, I think this is the wrong slide, actually. I'm looking for the administrative questions to billing and coding. Thank you. So Dr. Claire, how much involvement do you have with billing, coding, and the financial aspects of your practice?
Great question. So we, as surgeons, are responsible for all billing and coding for all E&Ms that we do as outpatients, so all evaluation and managements. We put in the diagnoses and we document the level of service that we've provided. And by far and away, that's the largest number of bills that we submit as physicians. For the operating room, we have the opportunity to code through the EMR that we have. Or if a physician chooses not to do that, we have professional coders who audit what we're billing and coding. And so they can, you can choose actually not to do that. In most of the instances, that audit is then returned to the physician so they can justify or approve the billing or change in billing that may have been done or change in coding. So, I mean, we're intimately involved, particularly for outpatient and for procedures that we do. You as a physician can choose the level of involvement that you want to have.
Thank you for that. And just a follow-up to that, Dr. Claire, for new physicians that are joining your practice and who may not have had as much experience in billing and coding during their fellowship, what training do you provide for those physicians, or is there a course that you send them to? What's your advice to younger surgeons joining a practice?
That's great. We're a small enough practice, and again, outpatient billing is pretty easy to teach someone. So we have actually an audit department that actually provides educational services for our surgeons. And then for procedural coding, essentially that's done through our group. There's 5 of us, and we actually interact on a regular basis regarding billing and coding if there are questions about it. And that has been pretty straightforward for us to manage.
Thank you. Makes sense. And the final follow-up to that question is, the professional auditors that you spoke of, do they provide feedback in terms of whether you are underbilling or overbilling for your practice?
So they do. They provide an audit regularly of our outpatient billing, and they'll look at, does the documentation justify the coding that was provided by the physician? And for procedural coding, they actually provide an email back to us through the EMR that says, this is how we're going to code this. Do you approve of this, or do you have questions or changes that you want to make?
Thank you for that. I appreciate it. We're going to move on to the next question. This is going to be about promotion and partnership. Thank you. So this question is for Dr. Sampson. I'd like to know how promotion, partnership, and buy-in and physician retention is approached in your practice.
But before I answer that, I would advise everybody to learn coding, because I think if you rely on an outside agency, you will be screwed. And you need to know coding in order to dictate. And the best way of getting the money back is to have an operative report that is so detailed in accordance with what the coding should be. It makes it much easier, even if you job it out to a coding person. So I do recommend that everybody learn how to code. And it's not that difficult. As far as promotion in our practice, we've gone through various models, but in general, when we hire a new person, we bring them usually for a year. At the end of the year, if the person is successful in the practice and wants to stay, they get an increase in salary and become partner at 3 years. Lately, what we've done, some of the people have come on so strong, so quickly, that we've offered them partnership when they feel that they can at least take part in some of the expenses of the practice. So it's really up to the individual.
I see. Thank you. Would anybody else from the panel like to comment on how partnership works in their practice model?
I wonder if I could just ask Russell a follow-up question to that, and that is there a buy-in for your private practice? Do the physicians have to pay anything for building or other equipment that you may have purchased as part of the practice in order to become full partner?
Very little, just the depreciated assets, which in essence, after 4 or 5 years can be a matter of cents.
Thank you, Dr. Sampson. I appreciate that. We're going to move on to the third question, which is about compensation. So this is for Dr. Suchdev. How would you say that your work is valued or compensated?
That's a great question. You can maybe tell me how it's valued and compensated. No, I'm just kidding. So it's valued in a number of different ways. So I have an RVU benchmark that I have to meet every year. The way that our contract works is it is renewed every year. I get paid by the University of Pittsburgh physicians, and I get paid from the University of Pittsburgh. And so there's two contributions, and actually that can get quite complicated because they're two different systems of, it's two different paychecks, two different W-2s at the end. So that can, and the rules are a little bit different from both groups. And basically, so I am compensated for whatever RVUs I make. I have a benchmark I'm supposed to meet. My PIT salary is dependent on on certain criteria on maintaining a certain academic productivity, I guess. And so I do have R01 funding from the NIH. I know that if I lose that funding and that doesn't get renewed, that will switch my category on the PIT side. And then I will likely have a compensatory adjustment on the UPP side. So, but technically that academic work is also supported. And, the more grants I get, the better for my PIT side, because I can justify that salary a little bit more easily. We also used to have a model in which, and I think our chief, Dr. Macaroon, had a very forward-thinking approach to this, so that things that weren't necessarily monetarily obvious to be compensated, such as teaching, such as being a mentor for residents and fellows, writing abstracts, presenting at meetings, writing papers, applying for grants, even if the grants didn't get compensated, didn't get funded. Those were all kind of given a small kind of RVU amount equivalent. And then that would kind of be distributed in some type of compensation at the end of the year. So I thought that was actually really good, because it gave an opportunity for those people who maybe were not the hardest hitting, clinical engines, and who were doing more teaching and doing more research and doing more abstract writing and presenting, et cetera, to gain some compensation for that. So yeah, that's how our compensation model works.
Sounds complicated. Just a couple follow-up questions to that. The first is, if you were to make beyond your RVU target, is there a bonus structure on top of that?
There used to be, and now it is different. And I'm not convinced that anybody in my system really understands how it works. It used to be that if you made beyond your RVU target, that you would get a certain percentage of whatever extra you brought in. And again, I thought Mac did a really great job of trying to be equitable about it, and kind of splitting that up so that part of it went to a group compensation and part of it went to an individual compensation. That is now no longer there. And so now I don't believe that there is a monetary benefit, if that's the right word, to go beyond your RVU target. Now, of course, I'd say the vast majority of us don't kind of organize our lives and our cases based on that. But that I know of, that is not the case at UPP anymore.
I see. And then finally, the only other follow-up I wanted to ask you was, do you have two separate tracks at Pitt, for example, where you have a clinical physician versus an academic physician, and that their work is valued differently? I know you said that there might be a slight RVU compensation for academic work outside of the clinical workhorse stuff, but I know that in my system we have two different tracks, and I'm just wondering if that's similar across your system too.
There are. It is different, but again, of course, it's like it is a behemoth, as Geetha said, and so it is very complicated. There are there are ways if you're academic to get promoted through the clinical educator or clinical like a clinical pathway, but you can also, your research and academic effort doesn't have to be huge. You can be basically on a clinical track with a small compensation coming from the University of Pittsburgh. Yes. So a long-winded answer to your question is yes, there are two separate tracks.
Thank you. So I'd like to move on to the next question. This is for Dr. Stradley. This is about autonomy over your weekly schedules. Wondering how much autonomy you have over your OR block time, meeting administrative time for the office, and also for vacation time.
Sure. So the way that we handle it in my group is we basically just agree amongst ourselves how we're going to divide that time, but it's divided fairly evenly between all of our partners, so that we all have an equal amount of time in the operating room, in clinic, or in our procedure room. So I feel it's pretty equitable, and we all sort of get our fair share. But certainly we can shuffle things around. If one of us has a more urgent case, then we can cancel some of our more elective cases and move that case into the slot. So I'm pretty happy with how we can change things around depending on what the need is for the group. And we sort of look at it for, what is the greater good for all of our members. And so, unfortunately, sometimes we do have to cancel elective cases to get things in, but we, explain that to our members and schedule them for another time.
Thank you. And the final question for this section is about malpractice. And this one I'm going to direct to Dr. Santine. This is a strange question, I think, for you as your solo practice, but how protected do you feel with regard to malpractice? How do you handle that in your current model?
Yeah, great question. I mean, knock on wood. I have a clean record. I've never been named in a lawsuit, and I feel really confident. I participate in the doctor's company. I've participated in their malpractice model since graduating fellowship. We have tort reform in Ohio, and so my malpractice is pretty reasonable. Pretty simple.
Great, thank you. We'll probably have others comment on some of these questions later, but we're going to move on to Dr. Hadro's section now.
Okay, well, again, thank you everybody for participating tonight. As a mid-career physician, I think this has been very informative for myself, and I've really enjoyed hearing the different perspectives. The last and final topic, which I guess will be the lightning round, really talks about the mentoring and peer review process. I think this is one of the more critical areas today in terms of recruiting staff, but also retention of staff. And I also think it's kind of one of the underappreciated antidotes to burnout today, that sense that we're all in this together. And, I think we're all very proud, accomplished people. And at the medical center, there's the opportunity, I think, to be lost without humility. And then when I hear Brian's stories, I think of sometimes when I was out there a little more on my own, and how challenging it is to plug in with somebody who can tell me that, many of these things are the patient, and it is the patient's disease, and it's not always us. So I think having that community is key. So that being said, the first question, and we'll run through each of you. So how is mentorship, both in the OR and in other clinical settings, provided either formally or informally? And we'll start with the experience of Dr. Sampson.
I think what you said in your lead up is terrific. I think that this is a grossly overlooked area. I must say, in the beginning, when I started practice, I was on my own. When I took in my first partner, I operated on every single case with him for a year, including toe amputations. That, of course, almost drove him to leave the practice, but he did. And now we were almost like twins by the time we finished together. In the practice at the moment, we do try, when a new person comes in, to make sure that there is one of the senior people with that person, at least until that person feels comfortable. And that may be on a case-by-case basis, or maybe just a period of time. But it is something that we do in our practice, that we make sure that there is somebody available. That ability to turn to someone who's been there before is absolutely critical.
Thank you very much. Dr. Sachdev?
Yeah, that I agree. I think this is such an important question and such an important point. I think the mentorship and the peer review and peer support aspect of the division that I work within is probably its shining achievement. And I think most people, I'm sure Geetha could say this too, that we have this Wednesday morning conference, which nobody misses. It's 3 hours of pure education, case review, M&M. It's really one of the most educational sessions, and we get to do it every week. It's really quite remarkable. And being part of a big group means that I have the opportunity, that I had the opportunity when I was a little more junior, to ask for help. I still ask for help if I have questions about a complicated case and I'm not exactly sure what the best approach might be. And now that I'm more senior, I'm able to provide that to the junior people who come in. And I think that this is one of the reasons. I could be wrong. We have a number of people who end up staying on in our practice after, not overwhelmingly, but they end up staying on after they've trained. And I think that's part of the reason, is because it's an incredibly supportive group of people. So I found that to be one of the best things about the practice that I work in.
Thank you very much for that thoughtful and detailed answer. Dr. Claire, at South Carolina, I know the importance of mentoring firsthand in the seriousness with which you take the role. What's sort of new down there, or lessons, things you've done different since you left Cleveland and started a new program? Any innovation or such?
Yeah, so in Cleveland, one of the things that we did was, because we had such a large group, we had 12 people at the main campus. I actually teamed less experienced physicians with more experienced physicians on teams of 2 or 3 surgeons together. And they would manage patients, discuss patients. And so I would be rounding on someone's patient who had just started the practice. So we could talk about, hey, what do you think we should do? What do you think about this plan? They could ask me. And actually, I asked them the same questions. We didn't have quite as large a practice here in South Carolina, and it took a while to build up to the number of practitioners that we've had. So one of the things I did was actually steal an idea from someone I know who's at Dartmouth now, and that is every morning, and this is what you remember probably, Neil, from your experience in the military. Every morning at 7 a.m., we have a morning report. I know Ben Starnes does this out in Washington. Yep. And we review cases that came in. At one day a week, we actually have an extra half hour where we talk about cases that are pending for the week, and we talk about all of the cases that we're doing, complex cases, areas where we've seen patients the week before in the office and we're trying to make decisions, and just the management of patients, because a lot of what we don't get, feedback about and interaction about is, how do you manage this patient who's had this issue after we did their surgery? What's the normal pathway for them? And so we review inpatients, we review cases that are coming up, and we review decision-making that we're talking about, looking at scans and other things as well. It's been very, very helpful for all of us, frankly.
Well, thank you. Yeah, I admire what you're doing. I certainly know from my own experience, there's often a tension for these non-compensated important jobs that we have, whether it's teaching new staff or supporting junior staff or taking time for education. It doesn't always show up in the box score when it comes down to the healthcare economics and ugly words like utilization and efficiencies and et cetera, et cetera, et cetera. And this is kind of our core being, and we have to fight to hold on to it and make this the best it can possibly be for ourselves, but it of course trickles down to our patients. So Dr. Santine, an Army, speaking of the Army, an Army of one, how do you handle, and it's not, I would say, just mentoring of other surgeons, but getting an OR staff, getting an office, getting the community to sort of rally behind you and help you provide your best self. So how about the comment on mentoring in your practice?
Yeah, I mean, it's certainly, as you allude to, it's definitely a hardship when you hang a shingle in a rural community and you're the only vascular surgeon. You know, although just like other aspects of life, I've relied on my mentors, whether it was finding an accountant, who was familiar with high wealth individuals during my general surgery residency, which banks to talk to about getting our first mortgage, or bouncing an upcoming case off of. You know, I routinely chat with my fellowship program director, Pat Muck at Tri-Health in Cincinnati. I know a number of you know Pat, or other surgical mentors from my fellowship or general surgery residency. And those I've gotten to know through membership, most notably in the Society for Vascular Surgery, but also the AVF. For the local community, I'm the one-man band, and you got to kind of bring that sense of, confidence, obviously, to building the practice. And, like they say, if you lead, they will follow. And, over the past 8 years now, building my practice, sometime COVID certainly hit us back numbers wise, but certainly within the next about month or two, I'll bring my 6,000th patient into the practice. So, but I definitely rely on my mentors for sure.
Dr. Stradley, I lost you on the screen there for a second, but please tell us about your experience in California.
Sure. Well, we certainly have formal mentoring programs within our organization, but I also wanted to mention that I do think it's important too to have mentors outside of your group. So fortunately, I trained not too far away at UC Davis, and I still contact some of my mentors there and talk to them about things. But formally within Kaiser, we have, case reviews every other week, and, my partners are just next door, so I can always ask them questions if I want to, bounce a case off of them. And so oftentimes we are, talking to each other throughout the day and getting a second opinion, if you will, about something if we're, stuck and need a little bit of help.
Great, thank you. You had mentioned before, we'll segue to question 2, but I think many of you have sort of answered 2 and 3 with these nice comprehensive responses. But you had mentioned working with partner on some difficult cases, aneurysms or so. And I think that's, wonderful patient-centered decision-making. But there's a little, I don't know, do you get some pushback or tension working for a system that you should be in the office that day, hitting targets where we know the OR is really where our needs are, in balancing that sense of, your ambulatory demands, your targets. I know in a managed care facility where the metrics are really sort of overseen daily, weekly, monthly, these first assists I've learned in my practice can catch up with me in the book. So how does it work? Are there pressures for or against working together in your system?
Yeah. So, in our system, if you can show a cost savings, that's sort of the biggest thing. So what we were able to do is show how we can reduce the time for our cases if we had 2 surgeons present. So for example, like a femtibial bypass, if we have one surgeon in the groin, one surgeon below the knee, we could show that we had a significant reduction in our OR time. And so that's sort of how we got the permissibility, if you will, to, have multiple surgeons in on cases. So our organization has actually been very supportive of having our surgeons assist each other. We do have a physician assistant, and we do occasionally have residents that assist with cases as well. But we do tend to have our partners help out with the more complex cases, and our arguments have either been the pure complexity of the case or the time saving, because the OR is the most expensive area for the hospital.
Great, thank you very much. Dr. Santine, is it, again, back to the army of one, is it better to, do you have a chance to collaborate maybe with other specialists or other community physicians, or is it more better to stay out of trouble than get out of trouble strategy?
Yeah, good question. And the full story too is I still do retain courtesy privileges down where I did my fellowship at Tri-Health in Cincinnati. It's about a 50-minute drive from my community, but if I do have a patient that requires say an open aorta or something that's certainly more complex, I call up Pat Muck and say, hey, I'm going to send, Bob down. We'll knock the case out together. We do it with the fellows. They follow that patient post-operatively in the hospital. So I'm not having to drive to Cincinnati every day, because I actually live on the south side of Columbus, so kind of opposite direction from there. And that's how we really kind of balance, the ability for me to do what I do, but still enjoy that ability to work with students and fellows and residents and do the more complex cases. But again, just they don't come up as often as they would in a larger tertiary care center.
Great, thank you. Dr. Sampson, many years of practice, successful and great retention. I would assume you're a strong proponent of partners collaborating and working together, and that the private model will survive that because the quality follows. Is that accurate?
I mean, in our practice, it's very capitalistic practice. Whatever you do is what you collect. So going into the operating room to help someone else is a waste of capital income. But we all realize that the patient comes first, and a difficult case requires two people. So open aortas are always two attendings, and we lean on each other frequently because we know that the other person is there to support us. So you learn pretty quickly, even though you may be competitive in a certain way. We all go down together, or we all rise together.
Thank you very much. I think, many of these three questions, when you look at them, do sort of all blend in together, and we're getting up against time here. Dr. Sajdev, you had mentioned something about, just your significance and success of the peer support system in your hospital. Can you just go back, comment again for the audience, how essential a strong hospital-supported peer support is in a successful practice and retaining physicians?
I think it's really important. I mean, I think that during our, they're providing a environment to be able to ask questions and get the advice of your partners about how to approach a particular case is really important. And I think the critiquing process is also equally important. So, like our M&Ms, like I mentioned, they're not always the most pleasant experience, but, you learn a lot from it. You learn a lot from how other people might have approached a particular problem. And if it's done in a way that is not punitive, but more about educating and trying to not make the same mistake again in the future, it's very, I think it can be very helpful. But, you can see how if you get defensive about that process, it can make it difficult. But I think keeping an open mind that the process is actually just there to help improve patient care, help improve education of our residents and fellows, help people learn from their mistakes, that it actually provides a very supportive environment for all of us, really.
Great. Thank you. And Dr. Santine, what kind of structure is in place in terms of peer support or quality do you belong to a registry, I would suppose? And how do you, measure yourself against the outsiders and the community, the importance of that, and the importance of checking, especially as the effort that goes in as a solo practitioner to sort of keep a scorecard and understand, sort of the pros, the good, the bad, of your practice scope.
Sure. So
how do you handle that alone?
Yeah, great question. So on my own, real hard. I mean, I compare myself against myself. I'm always winning, right? But the reality of it is, no, you have to be honest with yourself. So I do participate in the SVS VQI. I am also the chief medical officer of our health system, which is one of 89 hospitals. So I oversee our medical staff quality improvement committee, and in an instance such as mine, where I am the only vascular surgeon, we have a non-punitive kind of peer review process that we go through on a bi-monthly basis similar to a kind of an M&M, if you will, from my training back at the Ohio State University. Those tended to really, unfortunately, get maybe not as educational as maybe we would all like to think, and they got kind of malignant, if you will. Let's call a spade, and so we do this through a non-punitive atmosphere across these 89 hospitals, the LifePoint hospital system, and it's really helpful and it's beneficial to bring interesting cases and to be able to discuss them with your peers of other vascular surgeons that may not be in Wilmington, Ohio, but it works. You have to get creative.
Okay, great answer. Let's see, Dr. Sampson, in terms of peer review, you're an established private group. Is it all intrinsic, the peer review to your system, in addition to registry work? How do you look at monitor outcomes and complications in a large private group?
Well, we don't do anything intrinsically within the group, but we all participate within a peer review within the major hospital where we do over 80% of our work. So we are constantly being looked at by ourselves and by the other people involved in vascular care. And in our particular institution, our hospital, Sarasota Memorial, peer review is done not only by vascular surgeons, but interventional radiologists and cardiologists who also take an interest in vascular disease. So that can be quite an interesting meeting.
Sure. Dr. Stradley, is it more institutionalized peer review in the Kaiser system, or anything additional or innovative that your groups come up with?
Mm-hmm. So our peer review system also uses multiple specialties. So we do our reviews with interventional radiology and sometimes even with general surgery. So that's helpful too, that if there's a question of, quality in a case, that it gets reviewed by multiple specialties, not just our own.
Okay, great. I think we're probably running over time. So if there's some questions on the outside, I think there's a couple additional ones we wanted to get to. I invite Dan, Dr. McDevitt wants to join in with some of those questions.
Thanks, Neil. I appreciate it. Yeah, I didn't get a chance to introduce myself earlier. I'm Dan McDevitt. I'm the chair of the community practice section of the SVS. Since we have a few extra minutes, I did want to take the prerogative of the chair and ask a couple of questions. And I'm just going to go play Hollywood Squares. We'll go down the line with everybody. The first one is, what's the best part of the situation you're in? What do you like the most about the situation you're in? And secondly, what's the most frustrating or the thing you would like to change the most? And I'll start with you, Dr. Stradley.
Okay, wonderful. So some of the questions that fell under the administrative topic that we were on, I wanted to touch on. So this is a good opportunity to do that. Because Kaiser is such a big organization, and because we are the health insurance as well as the hospitals and the physicians, I actually am not responsible for any of the coding. I'm sure somebody somewhere does that, but what their philosophy is that, our surgeons should be focused on being in the OR, and whatever we can do to alleviate that, we will. So I'd say that's been very nice that, I really don't have to worry about doing any of that stuff. And then in terms of how we're compensated, we are salaried. So there isn't really a drive to have certain numbers or a competition amongst your partners for certain cases. And we do have an end of the year bonus that's sort of based on how the organization does as a whole. So that bonus is just how Kaiser Permanente is doing in Northern California. So all of us are incentivized to, help the greater machine that is Kaiser Permanente, and not just our own group and our own numbers. Our benefits are very good. We have a pension plan, which doesn't exist at all the Kaiser Permanente facilities, but for Northern California Permanente group, we do have a pension. We do have contributions by the Permanente group. We are given disability insurance, which covers 60% of our salary. And we are given life insurance that is 4 times our salary, as well as long-term care plans. So the benefits are are really good in terms of how they think about things that we need. We have financial planners that are assigned to us that specifically work with us on all of these, and so there's really not much they have to think about even in terms of retirement, other than attending the sessions that they have set up for you to make sure that you're doing all these things. So I must say, having a group that is physician run has a lot of benefits, because they are very focused on how happy their physicians are, and part of that is alleviating all the things that you have to do outside of work, including retirement planning and worrying about disability and life insurance. And even for malpractice, all of our members have to agree to arbitration. So we are covered in terms of our system has arbitration lawyers that cover all of that. So we don't have to worry about that aspect either. The one downside I would say to working for a big organization is sometimes you don't have a lot of freedom in terms of choosing things. So for example, we are going to move to another office space, and our medical assistant, because she's not senior in the union that she is in, we have to get a brand new medical assistant, and the person that gets chosen is chosen off of seniority, not based off of our input. So things like that can be a little bit frustrating sometimes, because you want to have more input on your work environment. And so sometimes they've taken out all the thought process to an extreme. But I'd say overall, they do sort of look out for us, and they have our best interests in mind.
Thank you. Dr. Sampson?
So I think it's clear. I think in a community practice like ours, private practice, it's the autonomy that is offered in a self-standing community practice. We've always been able to be one step ahead of government changes, hospital changes, environmental changes, and I think that makes us very quick on our feet. At the same time, when I say autonomy, if you ask what's the downside, there's also a lack of autonomy that comes when you have a bigger group, because you do have to subjugate some of your own personality to the group. And I think that's something that you learn pretty quickly. And that's why our group has survived with the same people here for so many years.
Thanks. Dr. Sachdev?
So giving this some thought, I think there's a tie between two aspects of my job that I find are the most rewarding and are the best aspects. One is that I actually get to blend a scientific career with a clinical surgical career. And that I think is really only possible in a few settings. And I'm in one of them, which I feel really blessed to be. And then that's tied with the next, or on the same level, best aspect of my job are my partners. I love them. I mean, and they are fantastic. They are friendly, they're helpful, and they're just fun to be around. So those are the best parts. And then the worst part of the model that I'm a part of is that I can't stand the modules that we have to do. And it's like this nonstop, never ending module for this, module for that, like I don't even know what they're for. Like, it gets to the point that you just kind of have to do these obligatory things that are part of, bloodborne pathogen training, and, you have to do blood, things like that. I can't stand that aspect of it, but I think that's a small price to pay for being really, really happy with my job.
Great. Dr. Claire?
The part of my job actually that probably is the most rewarding for me are twofold. One, or parts, I should say. One is actually we work in what was previously a very underserved community. We had one of the highest amputation rates in the country. And actually, we are changing that. There's actually clear evidence in numbers of amputations done in the city that we are reducing the amputation rate and keeping people on their feet, and we're keeping people out of the hospital. I mean, that's been very rewarding. And along the way, we've built a really great team. So this is a team of people where there was no one 5 years ago, literally no one. And so, all of the team members get along really, really well. We have a great group of people. And I don't just mean the physicians, our advanced practice providers, the nurses in our office. Our staff is really wonderful. I mean, that to me has been very, very rewarding. And the worst part about it has been that over the last 5 years, I've worked for 3 different organizations, 3 different electronic medical records, and the change is coming at times so fast it seems overwhelming. I love change, but it gets to the point where, and I'm sure all of us in medicine deal with this right now, that change just at times is an incredible burden to bear, in dealing just with all of that stuff at once.
And Dr. Santine.
Sure. Well, I think somebody mentioned, was talking earlier about kind of benefits and retirement. Just to clarify, as a salary, I make approximately about 25% of MGMA, for vascular surgeons. And that's not because I don't make much money. It's just that I don't like paying payroll taxes, much less taxes for that matter. So instead, I take a nominal salary as a vascular surgeon, and I take the vast majority of my pay through dividends to the shareholder of my company. That way I'm not paying payroll. We run a 401k through the practice that both my wife and I participate in, as well as we profit share with our employees. And that's a crazy great incentive to them to be more efficient, because the more money we make, the more money we all make. And by profit sharing, I'm able to maximize my 401k contribution to, I think it was $58,500 last year. Best part of running my own shop, I decide what I do when I do it, as long as my boss, otherwise known as my wife, she does double as my practice administrator. So as long as she approves it, well, it's not hard to do. But, I work as much as I feel comfortable with. That being said, I juggle many hats outside of my practice. As again, I mentioned earlier, I was named Chief Medical Officer of our health system last year. And whoever thought that was a good idea about a month before pandemic hits, well, I'd submit maybe they're an idiot. But it's been a fantastic experience. I was grateful for the opportunity to help lead our health system through the pandemic. Most recently, last month, I was elected as president-elect of the Ohio State Medical Association. So I have numerous time commitments outside of being a solo private practice vascular surgeon. And I'm busy as I want to be. And I've had to turn down opportunities to allow me to continue to do the things that I love doing. Do I work now more than I ever have? Absolutely. Would I trade my life for the world? Not a chance. I'd suggest that each of us owes it to ourselves to find that balance in life that really best suits you. I'm lucky. I think I found mine.
Great. And then just one last question, and I want to ask the two camps. Dr. Sampson, how do you deal with burnout in the private practice setting? I think you're on mute still.
No, I said, other than retiring, I'm not quite sure, but I don't really believe there is a true thing called burnout. I think there's something that happens to you as you go on into your career, where you don't get quite as much enjoyment out of the work as you did at the beginning. And if you call that burnout, then that's what it is. But I think it's something that each individual comes to at a separate stage in their life. And I don't think it's something that you can necessarily deal with, other than by being there for the person that is exhibiting issues that they can't handle themselves.
Great. And from the academic side, Dr. Claire?
Yeah, so, basically we use our meetings every single day to deal with the stressors that we deal with on a regular basis. And frankly, all of us have interests outside of just the jobs that we do. And, balance, I think, as Brian said, is important. Having outside interests is important, and having friends you can rely on and that you can, regularly interact with to provide support, particularly when things are not going well. A patient who's not doing well, we all know the weight of that burden that we carry around. And it's very meaningful to have colleagues support you through that. I think it's the only way we really get through it.
Wow, that's great. Well, thank you to everybody on the panel and to all our moderators. This was a fantastic evening, and I hope everybody who's attended tonight has a little bit better picture of physician employment models and maybe has a clearer picture of how they might apply to their own career goals. Again, I'd like to thank all the faculty and moderators for your time this evening. Everyone did an outstanding job. And I would like to say a special thank you to Dr. Chantel Moore, who was responsible for making all of this magic happen on a fairly regular basis, actually. I'd like to say goodnight to everybody, and I hope to see everybody in person at the VAM in San Diego. I think it's going to be a great event.
Thank you so much. Thanks for inviting me.
Thanks a lot.
Pleasure.
Thank you.
Thank you, everybody. Good night.
Great, thank you. On behalf of Society of Vascular Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this survey, as it will help Society of Vascular Surgery plan future web events. This concludes today's program. Thank you, and have a great day.